Hello, and welcome to the Advanced Methods webinars, sponsored by the Agency for Healthcare Research and Quality. Your moderator for today's program is Dr. Michael Harrison, Project Officer for AHRQ's Delivery System Research Initiative. The audio for today's webinar is available by telephone or audiocast. Audiocast quality is subject to your equipment, bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option and passcode provided in your confirmation email. Operator assistance is available to those on the telephone by pressing #. You may send questions or comments at any time by using the chat window located in the lower left corner of the presentation window. A question and answer session will follow the presentation. I'll now turn the call over to our moderator. Dr. Harrison, please begin.
Thank you for all of you for joining us. This is the fifth in a series of 5 webinars that's sponsored by AHRQ's Delivery System Research Initiative, which was funded under the American Recovery and Reinvestment Act of 2009. And these webinars are conducted in partnerships with AHRQ's primary care program. Our Delivery System Initiative supported research and demonstrations on large-scale changes in healthcare delivery, a very pressing topic in light of current health system reforms. The methods webinars help our grantees and other researchers use the most advanced methods available to plan, conduct, and report research on delivery system improvement. To start, Brianna Jackson, a member of our contractor team, will take us through some polling questions so that we can find out a little bit more about all of you. Brianna?
The first question we'd like you to answer is, how familiar are you with mixed methods designs and data analysis techniques? Please select the answer which most closely describes you. If you are very familiar, you've used them in research and or taught others how to use them. Familiar, you've read several papers and or attended presentations or training sessions on its uses, including applications to health services research. Somewhat familiar, you have read or heard 1 or 2 papers or presentations that use them. Or are you not familiar at all with mixed methods? We're still getting a few answers in. Okay, I'm going to go ahead and close the poll. And it looks like the majority of the people on the line here today are somewhat familiar with mixed methods. So now we're going to go to a second question here. And the second question reads, what is your general level of experience in health services research? Please select the answer which most closely describes you. If you have advanced experience, you've led 1 or more funded studies and have led publications on findings. Select intermediate if you contribute to successful competitive funding applications and peer-reviewed publications. If you're a beginner, you studied the field but have not yet taken an active role in preparing successful funding applications and publications. Or select other if, for example, you oversee but do not conduct research. And we're still getting a few responses in here, so I'm going to give it another second. Okay, I'm going to stop the poll now, and it looks like the majority of those on the line today are at an intermediate level in health services research. So now that we have a little more information about our audience, Michael Harrison will introduce our speakers.
Thank you, Brianna. Our first speaker today is Benjamin Crabtree, PhD. Ben is a medical anthropologist and professor and director of research at the Department of Family Medicine and Community Health at the Rutgers Robert Wood Johnson Medical School, and Ben served as co-guest editor along with Dr. William Miller on an AHRQ-sponsored open peer-reviewed issue of Health Services Research on Mixed Methods, about which you'll hear more in his presentation. Ben's presentation draws on the editorial introduction to that issue and on his many years of leadership in research methods and research on primary care. Following Ben's presentation, we'll hear from 3 leaders of the Care by Design team at the University of Utah. Dr. Michael McGill, chairman of the University of Utah School of Medicine Department of Family and Preventative Medicine and executive medical director of the university's health plans. And Mike is also director of research at the university's Community Clinics Community Physicians Group in Salt Lake. He's joined by Deborah Scammon, PhD, Emma Eckles-Jones, professor of marketing at the University of Utah, and director of the Masters of Healthcare Administration program in the School of Business there. Deborah is also an adjunct professor in the School of Medicine and Department of Family and Preventive Medicine at Utah. And the third colleague, Andrada Tomaya Cotusel, research associate in the Department of Family Medicine there. Their presentation will be based in part on research conducted under an AHRQ-funded demonstration grant on primary care practice redesign successful strategies. So Ben, at this point, I'd like to turn the discussion over to you.
Thank you, and good afternoon or good morning, everybody, depending on where you are. So Will Miller and I agreed to serve as guest editors for this special issue of Health Services Research on integrating mixed methods into health services and health delivery research. And during the time, we worked very closely with one of the associate editors at Health Services Research, Mary Fennell, and also with Mike Harrison from AHRQ. As we were kind of thinking about putting together the theme issue, we really wanted to achieve a balance of both methods and results. And in particular, we really wanted to get some methods articles on advanced principles of mixed methods and also on the challenges of putting teams together to do mixed methods. And both of these kinds of articles are included in this issue. And we also hope to have a diversity in results articles that would illustrate the different kinds of designs. Next slide, please. I should note that mixed methods really have been around for a long time, particularly in anthropology, sociology, case study research. However, it's really been in the last 20 years or so that specific definitions and terminology have emerged. And for example, in the 1980s, there were researchers like Alan Byman in the UK, Jennifer Green, and Kurt Stengi in the US, who were early proponents of combining qualitative and quantitative methods. And since that time, there's been a plethora of books, articles, and also, unfortunately, somewhat confusing terminology. However, I think most people who do mixed methods research would agree with the attributes on this slide. That is, mixed methods research involves the rigorous collection of both qualitative and quantitative data, and these are mixed by combining them sequentially or by embedding. Further, qualitative and quantitative methods, they can be combined in a single study or in multiple phases of a research program. It is also important to note that mixed methods design should be framed within a broader theoretical framework, so for example, case study framework or intervention studies, and that these kinds of designs should actually direct the study. I'll get more of that in a moment. Next slide, please. Just as a quick FYI reminder, qualitative research refers to the types of data that you get from interviews, observation, recordings, and existing documents, such as these on this slide. Next slide, please. So there's actually now many resources available on mixed methods, including a large number of journal articles that are summaries. Here's 3 of them, one by Curry in Circulation on cardiology, the Palinkas article on mental health, and the Zhang article on prevention. And now we have this special issue of health services research. Next slide, please. There's also a lot of books on mixed methods, and these cover a wide range of disciplines. Next slide, please. Finally, NIH commissioned a report on guidelines for mixed methods through the Office of Behavioral and Social Science Research. And this is available online, so that it's a nice guide that provides useful information on the design of projects, developing grant proposals, and reviewing mixed methods grant applications. So this is a useful resource also. Next slide, please. So today, I need a next slide. Oops, we went 2 slides. So anyway, today we want to introduce this special issue of Health Services Research, which is dedicated to mixed methods. Okay, next slide. And this issue includes an opening editorial by the guest editors, um, along with 6 papers. And these papers describe methods and report results from different types of mixed method studies. Next slide, please. So I want to draw attention to one of these articles. The article by Fetter, Curry, and Creswell is especially helpful in providing a nice overview of mixed methods and some suggested terminology. And in this article, they talk about 3 basic designs on which most mixed method studies are based. And this is followed by descriptions of different advanced designs. And as guest editors, one of the things we asked all the other papers in this issue to adhere by this same terminology so that there is a consistent terminology throughout this issue. So next slide, please. So just as examples, the exploratory mixed methods design illustrated here is in which you further exploration of qualitative results using quantitative data, and then next slide, which is contrasted with an explanatory mixed method designs, which actually begins with the quantitative data and results, with further explanations based on subsequent qualitative data. Next slide. Finally, and there's what we call convergent designs, in which quantitative and qualitative data are collected and analyzed simultaneously and results compared. Okay, next slide. So Fetters, Curry, and Creswell in this article go on to discuss 4 advanced frameworks that take off from those 3 basic designs. These are a multi-stage design, intervention designs, case study, and participatory. These are 4 different advanced frameworks, but they're all basically use those same basic designs. In addition, they talk about integration at the methods level, and so that they qualitative and quantitative data can be connected through sampling. You can build across data collection. You can merge different databases, or you can embed data collection and analysis. And finally, they talk about strategies for presenting your results. So in a minute, Deborah and her colleagues out in Utah will illustrate a number of these features. Next slide, please. So overall, this theme issue does a lot and has a bit of everything. In addition to the piece by Fetters, in the left column, Bowers et al. Provide some really essential practical insights on how to organize and sustain a research team that are crucial for conducting mixed method studies. And then, as you'll hear shortly, Scammon and et al. Illustrate the process of merging data using a convergent design within a case study framework where the qualitative and quantitative data are gathered at the same time. In the right column, Zickman et al. Provide a really richly documented example of integration through data transformation, where they start with qualitative data and transform it into a quantitative data. Hamilton et al. Illustrate the use of mixed methods in quality improvement research using a convergent design, while Glimmer et al. Illustrate the use of mixed methods in evaluation research using a hybrid design that combines explanatory and exploratory sequential designs. So really, there's a lot in this issue for everybody. Next please. So before turning this over to Deborah, I wanted to briefly reflect on some lessons that Will Miller and I have acquired from our own 20 years experience of combining qualitative and quantitative research. And first is it is important to really remember the research question and create a design that best addresses the question. That is, you don't change the question to match your methods. And because of the diverse skills required, mixed methods is best done in teams. And creating effective teams takes both time and relationship building. Since many of the research questions cannot adequately be addressed in a single study, you need to think both in terms of individual projects, but also how they fit into a larger program. And also be aware that numbers only provide part of an account, while reporting stories with numbers provides more compelling results. So think about regularly integrating qualitative methods into projects that start with a quantitative design. As you start putting together a design, select methods that complement each other. Don't duplicate strengths and weaknesses. And finally, when you are conducting a study, continually have team reflections and evaluate what is working and not working in your methodology. Next slide. So probably the biggest takeaway is that mixed methods requires diverse skills and works best in teams. Know your own strengths and weaknesses and find people who can synergistically complement those strengths and weaknesses. Slide. So I'm going to end here and turn this over to Deborah and colleagues from Utah who are going to illustrate a lot of these core attributes of mixed methods design from their study of primary care practice transformation. Thank you.
So thanks, Ben. This is Mike McGill in Utah, and I'm here with my colleagues Debbie Scammon and Andrada Tamara-Codicel. And I'll be kicking off our section of the presentation today with an overview of our Mixed Methods Research Program. It does draw heavily on the HSR paper on connecting the dots and merging meaning. If I could have the next slide, please. As Michael Harrison mentioned, our work has been supported by funding through AHRQ, two separate grants. Next slide, please. What I'll be reporting on is one major component of our ongoing work on primary care practice redesign, and that is a retrospective study using mixed methods, looking at the transformation that has been underway in the primary care practices in a network of practices owned and operated by the University of Utah. We've been implementing for about 13 years now a version of the patient-centered medical home. Our terminology here is care by design. I won't go into that in great detail, but to simply alert our listeners that when you hear us refer to care by design or CBD, that is the model of patient-centered medical home. And if you're familiar with the patient-centered medical home and other versions, it's a pretty good analog to what we'll be talking about here. Our major questions that we were asking in this retrospective study are shown on this slide. The first question was, what has changed? And so our first phase is to document transformation, document the process of change internal to the practices, and also to evaluate change within context, which has been at a system level for all of our sites, but also there's local context for each of the practices because they're located spread out throughout the Wasatch Front, which is the urban area in and around Salt Lake City. The second bubble there addresses our second question, which is how did our staff and physicians and other providers experience transformation? What's it feel like from the inside? What's their sense of success, their sense of the challenges? How are they coping with the amount of change that's entailed in medical home transformation? So we're interested in the experience of transformation. And then the third bubble looks at the outcomes of change. And here we're talking about outcomes in terms of clinical quality, financial performance, and patient, provider, and staff satisfaction. So those are the three major foci. And as we've heard, the complexity of mixed methods design can be great. And we'll be looking at our design, which has been a convergent design in the case study framework of a particular network of practices here at the University of Utah. Ben emphasized the importance of a team, and so what we see here is the team that we have pulled together, including multidisciplinary partners ranging from marketing and business to public health to clinicians, geriatrician, technical writing, biostatistics, economics, and organizational leadership. I can only emphasize what Ben had to say about the importance of an interdisciplinary or transdisciplinary team and the importance of maintenance of relationships and communication among the team as at least as important, if sometimes not more important, than the actual design of the research. Next slide, please. So I'm going to turn it over now to Debbie Scammon, and she will get into further detail about the methodology.
Thank you, Mike, and welcome, everybody. When we embarked on this project, I'm not sure that I actually understood what the idea of mixed methods meant. I certainly was conversant with multiple methods and had used them in a variety of studies in the past, but the step we took in this project was to actually try to merge the findings that we got from the variety of methods that we employed. And I think in the end we decide that we learned a lot, both in the process of doing it and about our transformation. So Ben referred to our project as a case study, built in the framework at least of a case study, and Mike described the study of our transformation over the last decade or so in the community clinics towards a patient-centered medical home. I'm going to try to use the terminology that Ben referred to, and I'll point out at various places where we think we did what he was discussing. Overall, I think we have both a multi-staged and a convergent design for our project. We intentionally included qualitative and quantitative methods so that we could understand whether in fact the findings from those different methods converged to some sense of what was actually happening. We collected data both sequentially over about a 3-year period, as well as concurrently in kind of spurts of activity, especially in year 1 when we did a lot of our new data collection. As we go through this, you'll see that parts of our design really are using quantitative data first and then followed by qualitative data to try to understand what was happening. In other places, we didn't know enough to begin with, so we started with qualitative data and then moved to a quantitative data framework to take a look and see whether we were coming to convergence. Today, what we hope to do is show you both the methods that we used in our multi-method in our mixed method design, and Andrada then is going to talk about a specific part of the analysis to illustrate how we merged the findings from various methods to get to our final meaning. So this slide is complex, and really all I would like you to pay attention to is the color scheme, and to note that different pieces were intended to address the 3 questions that Mike pointed out. So our first aim was to understand what transformation had actually taken place. And that, to look at that, we used primarily qualitative data that were already available, archived information and qualitative assessments that operations were already collecting. So that is the 2 red boxes on the left-hand side. We also used a confirmatory quantitative set of data to look at transformation, and that came from our clinic characterization audit, which I'll explain the details of in a moment. Our second aim was to understand the experiences of our employees as they went through this transformation. And to do that, we really had to look at qualitative data that would enable us to get into the minds of the people who are on the front lines. So we did a number of things. We did focus groups with patients. We did in-depth interviews with the employees, including the leadership, the providers, and the staff. And we did observations in the clinics to understand what was going on the ground. Those are the purple boxes. Our third aim was to take a look at the outcomes of change, and to do that we used a combination of existing data and newly acquired data. Our existing data came from operations, so we had financial and performance data from the clinics. We had the electronic medical record where we could look at clinical data, and we had ongoing satisfaction surveys of patients, providers, and employees. But we also acquired new quantitative data by using a specially designed employee survey periodically over 3 years. And we also acquired Center of Medicaid and Medicare Services data and from the Utah Population Database, quantitative data about utilization and cost of care. Next slide, please. Our study was not just a mixed method study, it was an extremely complex study. So I'm going to try to break it down and show you just one small piece of what we did over the first intensive data collection period, our first summer. So this slide illustrates that there were multiple people involved. Andrada was our key interviewer. I was the project coordinator, and we had a number of research assistants that helped with various aspects of data collection. The first thing that I did as project coordinator was to start with patient focus groups to understand from their point of view what they had observed as changes in our clinics over time. So that sort of set the base for our investigation for what was happening inside the clinics. At the same time I was doing the focus groups, I was also thinking about what kind of a survey of employee attitudes might be useful to us and what sorts of things we might want to include in that survey. When the patient focus groups are finished, Andrada took center stage, and she, in the next 2 months, completed 84 personal interviews with various levels of employees within the community clinics. That was a horrendous task for one single interviewer, but it paid off in that she had the continuity of the experience of visiting all of the clinics and speaking with the employees at each one of the clinics. The important thing also with her, not just that she did all of the interviews, but she was able to connect several of the other parts of our design. She was able to do some of the in-clinic observations while she was on site, and she was able to use the data collected in our clinic characterization audit to inform the interviews as she was conducting them in the clinic. So all of the parts and pieces fit together in the end, but it was certainly a complex design as we were moving through it. Next slide, please. So all these moving parts, one of the most important things was communication, and communication between Andrada and I throughout the interview process, communication between Andrada and the research assistants as she was comparing what she was hearing versus what they were seeing in the observations. That kind of communication was essential to making this all work. So this slide just very briefly shows you kind of the sequence of the things that we did during the project. We started out with an archival search, looking at documents that existed within the organization that could help us try to develop a timeline for when various aspects of Care by Design were implemented. We then did the clinic characterization audit to actually find out at each of the individual clinics what their patient volume was, what their staffing structure was, what their local competitive environment was like. Andrada then conducted the in-clinic observations and actually watched the patient flow within the clinics. How were the care teams interacting with each other? How were the members interacting with each other? What was going on in the daily operations of the clinics? She followed that with the interviews that I just spoke about, and she'll tell you more about that. All of that happened in about a 2-month period in year 1. In years 2 and 3, we then ventured to get additional quantitative data from the outside. That's when we got the CMS data and the Utah All-Payer Claims Database data. That's a story in itself, which we may come back to. And through all the years, we were collecting additional survey data. Next slide, please. So our design was intentionally complex Going in, we thought we had a pretty good idea of what data we would have access to and what data we would need to add. But as we went through the process of actually obtaining the data, we learned what we didn't have access to. So for example, we knew we had access to operational data. The clinics agreed to let us have those data. What we didn't realize was that not all of that data would be easily available to us. So for example, one person in the clinic had access to querying the database from the EMR and querying the electronic medical record. We were entirely reliant upon him and no contingency plan. The infrastructure was already in place for collecting and reporting a lot of the operational data, so that was definitely a positive thing. But the data weren't always what we expected them to be. So for example, our Care by Design model over a 10-year period actually evolved so that we introduced new elements to that model. And the measurement of those needed to change. So we don't have a consistent set of measures of implementation of elements of our care model over the 10-year period because new elements were introduced periodically. Next slide, please. The other aspect of working with an ongoing clinic as a partner in this complicated research project was that we had to fit our new data collection into the working operations of a clinic. So we had to take into consideration their workflow and their schedules. Despite the fact that we tried to plan ahead and scheduled provider and staff interviews to coincide with slack times or even to block out times for the interviews and provide compensation for the interviewees, things would come up. One provider would have a particularly hectic day on the day that we had scheduled the interview. An MA would call in sick and not be there. So we had to go back occasionally to pick up pieces of data that weren't available the first time through. So we learned to be quite flexible and to walk softly. I think another major advantage of our project was that we had the cooperation of senior leadership and management of the clinics. They wanted to learn as much about what was going on as we did. Not necessarily the same things, which I'll come back to in a minute, but they needed to be kept in the loop, so we periodically reported back to them. After our intense summer, we reported to a retreat that senior leadership held, and we've reported 2 or 3 other times. Most recently, just a week ago, we met with them, and they've asked us now to write some narratives, some stories about what we're learning for an employee newsletter. So we count that as a great success in terms of being able to show management what we've learned that can be helpful to them. Next slide, please. I'm going to now turn it over to Andrada, who is going to try to explain some of the intricacies of how we wove this all together.
Thank you, Debbie. So now an example of merging data to make meeting. During this presentation, you will notice the integration through weaving and also the joint display of results. So a review of implementation data by clinic revealed that one clinic, frequently referenced as an exemplar of the model, actually demonstrated only average implementation scores. We speculated that this aggregation could be disguising some differences in implementation among teams in this clinic. Next slide, please. This slide. Given this average performance, our first question was, does performance vary among teams within this clinic? This slide presents CBD implementation data for selected measures of planned care, and we see that Team 5, led by Provider B, has higher implementation scores than Team 1, led by Provider A. Yes, performance does vary among teams within this clinic, but why? Why were teams in the same environment practicing so differently? We hypothesized that differences might be related to providers' commitment to the vision for CBD. Provider A states, but I'm also one of the busiest providers, so it's more a matter of, what works for me. Provider B states, somebody comes in for bronchitis and hasn't had a mammogram, hasn't had a colonoscopy, hasn't had a flu shot. You have to slow down to provide all of those quality issues that you need. Provider B appears to be more committed to the vision of CBD, while Provider A appears more concerned with productivity. Our quality data suggests that the time needed to provide comprehensive care impacts how providers implemented CBD. Next slide, please. With this in mind, we proposed a new hypothesis, namely that commitment to CBD implementation was higher among providers who emphasized quality over productivity. Remember, Team 5 had higher implementation scores. Looking at quality scores, the first table on this slide, specifically percent of patients receiving recommended screenings, we see that Team 5 also has higher quality scores. But looking at the second table, we see that Team 1 has higher productivity scores. Productivity is important to financial solvency of the clinic. Quality is important to patient health. Given the tension observed, we hypothesize that attempting to increase either or both puts a burden on the care team. Next slide, please. So this was our next question. Does attempting to increase either or both productivity and quality put a burden on care teams? Again, remember Team 5 has higher implementation and now higher quality scores. Looking at employee surveys, in particular the team development measure and dimensions of Maslow's burnout inventory, we see that Team 1 reported a more unified team identity, and that they also rated their level of burnout as generally lower than did Team 5. To better understand this tension, we went back to qualitative interviews. An MA on Team 5 reported that we drop in all the history from any labs done, any radiology done, and we get those specialty results and we have them sitting on the desk in the room for the visit. An MA on Team 1 reported, with other doctors, yes. On Team 1, no. We have so many regulars. Team 5 MAs appear to prioritize pre-visit planning, while Team 1 MAs prioritize productivity when practicing with Provider A and adjust when working with other providers. Next slide, please. So using mixed methods, we were able to document variation in implementation and outcomes. And we were also able to elucidate tensions between productivity and quality, specifically to explore differences in the way providers approach redesign and differences in the MA's ability to implement. And so doing, elucidate the resulting impact on team members. Next slide, please.
Thank you, Andrada. So I will try now quickly to make some major points about what we think the value of mixed methods research was for our project specifically, and then Mike's going to wind up with some conclusions about our experience overall. Using mixed methods really enriched our understanding of the reasons that certain changes were taking place, the reasons why certain changes were more difficult than others, and the reasons why changes were more difficult in some clinics than they were in others. So it really gave us an opportunity to see that quantitative data told us what was going on. The qualitative data helped us understand why some of the things that we were seeing in the quantitative data were happening. Mixed methods, as Andrada said, enabled us to both generate and test emerging hypotheses. As a case study, we intended this project to primarily describe our experience with change, but by using the data sources iteratively, we were actually able to develop some more detailed hypotheses about what was happening and why, and we were able to test those within the context of the data that we'd already gathered. Through the use of mixed methods, we found that in another study that we another report that we have published in the Annals of Family Medicine, we report that continuity with a primary care provider was correlated with quality measures, with provider and patient satisfaction measures, and with financial performance measures. Had we not included measures of all of those, we would have missed the substantial relationship of continuity to all four of those categories of outcomes, which was a significant insight for us. Next slide. As Ben said, qualitative data can give us stories. They can give us narratives. They can tell us what is going on the ground with experience with change. Quantitative findings give us a way to calibrate the amount of change that's going on and how it's affecting people in the organization. So together, the qualitative and the quantitative data provide insights that are actually helping the community clinics move forward with their strategic planning. Based on the data that we've reported to them, community clinics is redesigning some of the clinic functions. They're redesigning some of the roles that individual members of the care teams are playing, and they have definitely prioritized continuity of care and are building that in as a key principle in the care by design model. Next slide, please. So I'm going to hand it back to Dr. McGill now, who is going to draw some final conclusions. I just want to say that if you haven't decided this already, mixed methods are extremely tedious, extremely time-consuming, but they're fun and they're worth it.
Absolutely. So thanks, Deb. Just a few kind of take-home points that build on what Debbie just had to say, and there are three. First is the value of mixed methods in our experience is that we clearly have a much more nuanced perspective on the implementation. It's been a multi-year implementation of a patient-centered medical home model in a 10-practice system operated by the university. Appreciating multiple perspectives of different players in the process of transformation is like different individuals feeling different parts of the elephant. And our goal, of course, is to gain a picture of the elephant as a whole. And we find that the mixed methods and multiple observations give us a much richer meaning than available from any one individual source that may only be looking at one part of the process. Next slide, please. The second is that we appreciated one of the benefits that we had in this process, and that is that the research team was intimately linked to the operations. Our research team included members from the medical leadership of the clinical practices. We drew on data that were coming from the clinical practices themselves, as well as generating new data, and we built a feedback loop so that it's an ongoing relationship. Rather than the alternative, or one alternative, which might have been that we were working at a much more arm's length, at which point it would have been much more difficult to really find out what was going on inside the organization. Next slide, please. And finally, the last point about value of mixed methods is that they reveal inherent tensions within an organization. And Andrada talked about the tension between implementation of team versus focus on productivity. That's just one example of a whole series of tensions. And the value of the mixed methods is it really makes you focus on the conflicting tensions within an organization that need to be managed, which is a much richer and more productive approach, I think, than a more static sense that we're measuring one particular aspect and only trying to influence that. This is a complex system, and the mixed methods really enable us to assess and understand and work within the complexity. So with that, we'll stop our portion of the talk and turn it back over to Michael.
Well, thanks to all three of you and to Ben for two very exciting and stimulating presentations. I want to encourage all of the folks who are on the phone and the web to take this opportunity to pose questions to either or both of the presenter teams. And while you're doing that, I just want to mention 2 points that stood out in the presentations for me. One is that in the examples that Andrada gave, there were illustrations of using qualitative information to generate hypotheses and also using qualitative information or data to assess hypotheses. And there is a view out there which is often heard that qualitative data are very helpful for developing hypotheses, but you got to have hard data, i.e. quantitative data, to test them. And I think Andrada gave some examples where the testing was both quantitative and qualitative. The other point that was made both by Ben and by the Utah group relates to the value of doing mixed methods research in terms of enhancing engagement between the research team and the stakeholders who are either permitting or paying for or the research or asking for the results. So those are just 2 points, and with that, I want to turn to some questions that are coming in here. There's a question here by Daniel. Given the complexity of mixed methods designs and the time factor, do you have any thoughts about how to effectively approach grant writing for mixed methods studies? That's obviously a major challenge. Do either of you want to comment on that, either Ben or one or more members of the Utah group?
Well, I'll take a shot at that briefly. This is Mike in Utah. I think the approach to grant writing really needs to return, in a sense, to sort of grant writing 101 in this way. It's important to step back and consider what the big question is that we're asking. So our big question was can we learn about the transformation that's occurred? And with the major question firmly in mind, right in front of us all the time, then we start drilling down into the details and saying, well, what do we mean by that? Well, what we mean by that is, did people actually change their behavior? And then the next question becomes, well, what's the best way to assess that behavior? Well, we can watch behavior, so that's observational, qualitative work. And we can measure behavior, so we can look into the electronic medical record and see evidence there of the different roles that clinicians and medical assistants and others take, the traces that they leave of their change in roles as they go through their day-to-day work. So I think my main point here is keep the big question in mind and then drill down into the details and be open to the variety of methods that may be most useful to assess the individual questions.
So this is Ben. One of the things that is really helpful is to put a diagram in your grant application that really shows how the data are, so those simple little diagrams that I put on there, there were 3 different, fill in those boxes and so you have, you're going to call it a sequential exploratory, sequential explanatory, and put the information in those boxes of how your project's going to fit together, or if it's a convergent design, and that goes a long ways to helping the reader understand what you're doing.
This is Debbie in Utah. I might add to that, that same diagram and that same explanation, it would be very helpful to your IRB. We had a lot of difficulty getting our IRB to understand why we needed to link certain data to other pieces of our project, and those diagrams are very helpful in that regard.
Terrific. So there are a number of other questions here, and there's one question which you folks may want to venture an answer to, or you may just want to provide some references. It's a classic question, and it comes from a gentleman by the name of David B. He says, with the convergent study design, how did you address the issue of causality? And then comes in back again and says, in other words, how were alternative explanations for observed associations evaluated? I think this may be heavily a question about qualitative methods, but one could see where the mixed methods part of it could play as well. Does anybody want to tackle that one? Want me to repeat it? It's a toughie.
Yeah, I'm not sure I'm grasping the question.
You want me to repeat it, Ben?
Yeah.
Okay. I'm going to read it off here because it appears actually twice. Unfortunately, now my screen is not showing it, so I got a technical issue here. I had it and it's gone. The question was, how do you address causality, and how do you eliminate alternative explanations for a phenomenon?
This is Andrada from Utah. I have one suggestion. We use the qualitative data to understand what the quantitative data were telling us, and sometimes we saw only average results with the quantitative data, and looking at the qualitative data, we were able to see why the variation involved and why that variation existed, and specifically the tensions that were involved, the mechanisms. And so while quantitatively we were only able to say that there's an association between this and that, qualitative data were able to help us to understand the causal mechanisms involved and the potential various causal mechanisms.
And also, when you're doing mixed methods, you're using multiple different kinds of methods, and so you're getting different snapshots of the same phenomena. And when there's consistency in that, that really helps you understand why certain, I'm not sure if that gets at causality, because I'm not quite grasping how far you want to take a causal relationship.
Well, I think it's helpful, and I just want to emphasize two concepts, at least in my own terminology, that came out of those responses. I think Ben's response is really focusing on triangulation, the multiple sources of data on the same phenomenon, which certainly gets at the issue of validity and may also get at, whether linkages are actually there or not. And then I think the earlier remark that Deborah made talks about observing sequences, and I think that's one of the issues where qualitative research varies from a fair amount of quantitative research, although clearly there are possibilities for doing sequential analysis that's quantitative as well, but it's not done quite as often as it might be. And when one can trace a series of links in a sequence, I think it adds conviction that there is indeed a causal linkage. Let me turn to another question here, which I think is a terrific one, and that is, how do you teach mixed methods to doctoral students, given that dissertations are rarely teamwork projects?
That is hard. I actually, when I was in graduate school, I tried to convince this was 30 years ago, the university to allow team-based dissertations, and that was not accepted. I think you can work so one of the things that I do now is work with, on my projects, I will involve doctoral students who can they can work as part of that project. They can go to the team meetings, they can collect data on their own dissertation topic, so that there are ways of collaborating with a larger group and collecting data with that larger study, and still have it as your own piece of work.
And if I could jump in, this is Andrada from Utah. I'm currently a doctoral candidate. So these data are data that I'm using for my dissertation, and I am part of this research team here at the University of Utah and using the data that we collected under these grants, but I'm also asking, I'm further exploring some of the tensions that we identified in our initial analysis and using system dynamics methods to create that causal map, that the systems diagram, the causal loop diagram, and then a quantitative model of the system and how it operates, so we can try to see the elephant. And that's kind of going a little bit further than taking the analyses and the data a little bit further.
I could just add, this is a little bit facetious, but I may have it all wrong after 30 years of teaching doctoral students. I seem to always be part of their team. So they aren't doing individual research, but they are involving all of their faculty members. And in our program here at Utah, they often are using other doctoral students to assist with parts and pieces of data collection. So it truly is a team, although it may not be a team-written dissertation.
Okay, that's very helpful. I'm going to go to another issue altogether here, and we have a bit of an embarrassment of riches here, but I love this question. If you didn't have a grant to fund this type of research, what would be the best pitch or pitches to convince a health system CEO to conduct this type of research on an ongoing basis? And that also relates to an earlier question we had about the burden that data gathering places on the staff. Now, you did address that, but you may want to address that a little bit further in thinking about how would you pitch this to a busy CEO or COO?
Well, so the changes that we implemented here actually for many years were being implemented by the delivery system, and the research program came along quite a bit later to evaluate the changes and to help push them forward. I don't think of this as an either-or proposition. I think it is challenging to ask an operational CEO to fund what they might perceive as some sort of an add-on. It's much more, I think, possible to work with the delivery system when the changes are being implemented and that you're trying to measure and advance fit into an evolving business model, such as reformed payment for care, and that rewards the kind of information about improved quality and improved cost that emerge from the transformation. And in that environment, basically the bottom line is dependent on effective transformation. And we've had a certain amount of traction for that, but what I must say is that we've seen more of a dialectic between the delivery system and the research, where one leads to benefits for the other, and in turn the other returns the favor, where our research has improved the quality of the performance of the delivery system, which in turn gives us next opportunity to do the research, which again is applied and helpful to the organization.
And I would also try to make the case that what happened, so that there are interventions need to be constantly monitored and changed over time, and so if you're doing an organizational change and you just wait to the end and it doesn't work, then the business case is really poor. So adding in an ongoing mixed methods evaluation component where you can get regular feedback and should be part of most of these implementations.
And to that point, looking at the example I just presented, the tension between productivity and quality wasn't necessarily new. Senior leadership had already identified that as a tension, but what we were able to offer was an understanding of the mechanisms behind that tension and why we saw the variation that we did within our system.
I just add to Ben's observation, I think there's an element of good fortune that occurs when you've got management that's sensitive to the kinds of issues that both the Utah team and Ben raised. We have had instances where we've talked with delivery system leaders who are doing really major transformation projects, and we've asked, well, have you got some kind of an ongoing evaluation or tracking program? And they said, oh no, we're just moving ahead with this because we're convinced this is the way to go. And we're kind of shaken in our boots when we hear that, because we know from our experience of talking to people and from the research literature that has been mentioned, a lot of things happen along the way. There are a lot of emergent and unintended developments, and if you don't have your finger on the pulse as a manager, I'm not talking about as a researcher, but as a manager, if you don't have your finger on the pulse, there may be some unpleasant surprises. So I think that is a very, is a potentially strong pitch, but it has to be made to a receptive group of people. I'm going to dig in here for another question. There are a number of questions about the iteration process of moving back and forth between the different phases of the research that were described in the Utah project, and I want to see if I can capture that here. How quickly did you change your questions? For example, in the Team 1 and Team 5 example, how much data did you collect before asking a new question? Can you say more about the iterative analyses in the Utah project? This is a separate question. Much of the data was presented in a linear fashion. To what degree did the data collections inform each other? So I have a couple of people who are picking up on that theme of telling us a little bit more about how you move from one data collection or data analysis phase to another.
This is Andrada from Utah. Several thoughts. One thought is regarding the observations data and the interview data, and Debbie already mentioned a little bit about this. We conducted the observations and the interviews at the same time in the clinic. So we went to a clinic for 2 to 3 days and observed the workflow, the way that teams interacted with each other and with other teams, and also interviewed providers, medical assistants, center managers in that clinic. And since we would have interviews interspersed, observation, interview, and so we could ask, when I observed a particular incident, I could ask about it in the interview since it was semi-structured. So in that sense, observations informed the interviews, which were done in the same point in time. However, with the survey instruments and with the implementation data, those pieces of data were gathered at particular points in time. And once we had them, we were able to use those to answer the hypothesis, the questions that we were generating. So later in the analysis phase, we drew upon those initial data.
And Andrade, I want to thank you, and I'm watching the clock, which regrettably is reaching the 1 o'clock hour. I want to turn over to Brianna. Before I do that, I just want to thank all of the presenters and all of you who were on the phone or on the web, and remind you that information about access to the methods briefs and the health services research issue and the eventually posting of the webinars is provided on your screens. Brianna?
This concludes today's Advanced Methods webinar on mixed methods. Papers for the HSR special issue are currently available at the address on your screen. Also listed on your screen are the addresses for previous webinars in this series and the address for the entire series of AHRQ PCMH Research Methods Briefs. Thank you for attending. Have a nice day.